Juniper Owens, Director of the Academy of Integrative Mental Health, and your host for today's episode, which is a mental health news updates. So we would like to bring to you the latest news and mental health topics so you can stay up to date in your field. So first, let's start with the research review. I looked at a study that reported that major political events affect the public's collective well-being, sleep, and mood. So it might seem counterintuitive that major socio-political events could be harmful to one's sleep, mental health, mood, and overall well-being. But this groundbreaking study investigated the extent that the 2020 U.S. presidential election impacted sleep, public mood, and alcohol consumption. It also explored the relationship between affect and sleep changes during the peak period of election stress. The findings published in the National Sleep Foundation's journal Sleep Health show that divisive political events negatively influenced a wide variety of factors related to public mood. One of the study's authors, Tony Cunningham, PhD and director of the Center of Sleep and Cognition, said, "Our results likely mirror many of our own experiences surrounding highly stressful events, and we felt this was an opportunity to scientifically validate these assumptions."
That deep emotional brain center was in fact hyperactive. Indeed, the amygdala was almost 60% more responsive under conditions of a lack of sleep. But why was that the case? And what we went on to discover is that there's another brain region that's involved. This brain region is called the prefrontal cortex, and it sits directly above your eyes. And you can think of the prefrontal cortex almost like the CEO of your brain. It's very good at making high-level, executive, top-down control decisions and reactions. In fact, it's one of the most evolved regions of our brain. And one of the parts of the brain that it controls is this deep emotional center, the amygdala. Now, in those people who'd had a full night of sleep, there was a nice, strong communication and connection between the prefrontal cortex, regulating that deep emotional brain center. But in those people who were sleep deprived, that communication, that connection between the prefrontal cortex and that deep amygdala emotional brain center had essentially been severed. And as a consequence, the amygdala was responding far more reactively due to a lack of sleep. It's almost as though without sleep, we become all emotional accelerator pedal and too little regulatory control brake. And that seems to be the reason that we become so unbuckled in terms of our emotional integrity when we haven't been sleeping well.
So in the study, there were 437 participants in the U.S. and 106 international participants who completed daily surveys between October 1st through the 13th, 2020, before the election, and also October 30th through November 12th, 2020, which were the days surrounding the November 3rd U.S. election. Each morning, the respondents were asked to assess the previous night's sleep by recording their bedtimes, time required to fall asleep, number of awakenings through the night, morning wake time, and time spent napping during the day. They also recorded the previous night's alcohol consumption. Mood was assessed using a validated questionnaire as well as questions from a standard depression screening tool. Now, with regard to sleep, both U.S. and non-U.S. participants reported losing sleep in the run-up to the election. However, U.S. respondents had significantly less time in bed in the days around the election. On election night itself, U.S. participants reported waking up frequently during the night and experiencing poor sleep efficiency. U.S. participants who ever reported drinking alcohol significantly increased consumption on 3 days during the assessment period. Those were Halloween, Election Day, and the day the election was called by more media outlets, which was Saturday, November 7th. Among non-U.S. participants, there was no change in alcohol consumption over the November assessment period. Analysis revealed that stress levels were largely consistent for both U.S. and non-U.S. participants in the assessment period in early October, but there was a sharp rise in reported stress for both groups in the days leading up to the November 3rd election. Stress levels dropped dramatically once the election was officially called November 7th. This pattern held both for U.S. and non-U.S. residents, but changes in stress levels were significantly greater in U.S. participants. The U.S. participants also reported a similar pattern with depression than their non-U.S. counterparts did not experience. However, non-U.S. participants reported significant decreases in negative mood and depression the day after the election was called. This is the first study to find that there is a relationship between the previously reported changes in election day public mood and sleep the night of the election, Cunningham said. He also said, moreover, it is not just that elections may influence sleep, but evidence suggests that sleep may influence civic engagement and participation in elections as well. Thus, if the relationship between sleep and election is also biodirectional, it will be important for future research to determine how public mood and stress effects on sleep leading up to an election may affect or even alter its outcome, end quote. A common self-care tip that is shared wildly in social media posts and conversations is to just tune out and reduce or stop consuming news media altogether. However, this approach solely focuses on the responsibility of the individual to deal with the stressors of the political climate and the way elections and other major events are presented by media outlets, political commercials, and rallies, just to name a few. As mental health providers, it is important to take into account all of the factors of how political events shape our clients' well-being and to brainstorm ways not only to cope with the stress, but also normalize the very real impact that the world has on individuals and communities, especially the most vulnerable who have mental health diagnosis or any other factors that could be exacerbated by world events. We can advocate for more community resources and supports that could facilitate civic engagement, which can be empowering and support well-being. Next up is an advocacy alert. Content warning, this story discusses suicide. Healthcare workers deserve stigma-free, accessible mental health services. The All-In Wellbeing First for Healthcare campaign was developed by #FirstRespondersFirst and the Dr. Lorna Breen Heroes Foundation as a coalition of leading healthcare organizations committed to the prioritization of the well-being of the healthcare workforce and making progress on the barriers against persistent mental health and well-being challenges that disadvantage our healthcare workers and therefore our healthcare systems and the future of public health. Dr. Lorna Breen, an emergency room physician, died by suicide in April 2020 after weeks of incredibly intense work caring for patients in the first wave of COVID-19. At one point during that surge, Lorna called her sister to confide that she was overwhelmed with exhaustion and grief, but she was fearful that she would lose her medical license or be ostracized at work if she acknowledged that she needed help. Here's a clip of her husband talking about her life and her experience with receiving mental health treatment.
She was a very driven physician. She contracted the virus herself and tried to recover at home. When she didn't have a fever for 24 hours, she called and went back to work. She was scheduled for 10 12-hour shifts in a row, but she wasn't working 12 hours. She was working 15 hours and 18 hours. Patients dying in the waiting room where their portable oxygen would just expire, and not enough beds, not enough help. She called us and said, this is going to end my career. My colleagues are going to be able to recognize that I can't keep up. And we said, then you should go home. But she didn't, because she was a dedicated physician, just like so many healthcare workers. Only a handful of days later, she called Jennifer and was basically in a catatonic state. She couldn't get out of her chair. At that point, we solicited the help of some of her childhood friends and her medical school friends to get her physically out of Manhattan. Lorna was in really rough shape, so Jennifer, she drove her big sister to the hospital, like you do. Lorna spent about 10 days in the hospital, her first ever mental health treatment. And only a day or two into that mental health treatment, she started to call home and say, now that I've gotten help, it's gonna ruin my career. I'm going to lose my license to practice medicine. And we thought, how could that be possible in this day and age? Unfortunately, that fear of basically her career being over was one of the things that we believe contributed to her decision to take her own life. And that's when Jennifer and I decided in a moment of calm that we needed to tell her story. What we know is that the pandemic has had a significant impact on the mental health of the workforce, which goes beyond just burnout. It goes to things like PTSD and depression, and ultimately potentially suicide. The giving culture plus the competitive nature and how many hours they spend doesn't lend itself to self-care, and that takes a toll, and that needs to change.
In the years since Lorna's death, the Dr. Lorna Breen Heroes Foundation has heard from many families who have lost physician loved ones to suicide. Like one emergency medicine doctor in Florida who reported that 4 of her physician colleagues died by suicide the previous summer. In too many of these cases, the clinicians have acknowledged to friends or family that they are reluctant to get treatment because of the stigma around mental health issues at work. The Dr. Lorna Breen Healthcare Provider Protection Act has provided $135 million for programs aimed at supporting the mental health and well-being of health workers. However, while this was a welcome first step, it's only the beginning of the work needed to protect our clinicians and healthcare providers. Their research has identified 31 states, plus the District of Columbia, that may still use invasive or stigmatizing language requiring applicants to disclose any history of mental health concerns or to explain why they have taken breaks from work. Some require applicants to disclose any past psychiatric treatment, potentially going back decades, even to adolescence. These questions might violate the Americans with Disabilities Act, and they certainly violate applicants' privacy. And there is a significant evidence that they deter clinicians from seeking the care they need, at tremendous risk to their well-being and their lives. Indeed, a survey of more than 1,500 physicians conducted this year found that 80% agree there is stigma around doctors seeking mental health care. Nearly 40% reported that either they personally or a colleague they know has been scared to seek mental health care because that treatment would need to be disclosed on their licensure, credentialing, or insurance applications. Like everybody, healthcare workers deserve the right to pursue the care they need whenever they need it, without fear of losing their license, job, or promotions. This is especially important now as healthcare workers have reported sharp increases in emotional exhaustion due in large part to the extraordinary strain of caring for patients while also enduring a surge of intimidation, threats, and physical violence during the COVID-19 pandemic. And from what I'm hearing, it's still continuing. I reached out to many healthcare workers, including physicians and nurses, and most did not want to speak out in fear of being stigmatized at work, reported to their licensing board, or potentially ruining their careers, mirroring the same issues raised by Dr. Lorna and so many others. The nurse that did agree to be interviewed for this story asked for their identity to remain anonymous, so we blurred their face and changed their voice. This really spoke to the fear healthcare workers embody talking about their own mental health and that of their colleagues. Here's a clip from our interview discussing the potential negative effects of receiving mental health care treatment.
Like, your mental health becomes a risk. So you're a risk to patient care, you're a risk to yourself, you're a risk to the team, because you all have to work together. So if you're a risk, what does that mean? And where does that place you? So do you want people to know how you're really feeling? Do you want to express how that is fully? No. You have to even think about licensure in particular. If you were to report that you were institutionalized or something like that, or seek help for long periods of time, outpatient therapy or inpatient, either way, I think that it would definitely be a negative for you in the healthcare field because, oh yeah, I know what I was saying now, sorry. The KBN or something like that, licensure boards, people have to be reported for certain things. So if anyone thinks that someone is being an unsafe nurse, and there's some little stipulations to that, but it's almost a general statement. If they think that if anyone believes that a nurse is being unsafe to patients, they can be reported to the board, which then will cause an investigation of that nurse. So that's a really huge deal. They could lose their license, they could be out of a job, that's livelihood. That's, it's a really big deal, especially when it's a woman driven career.
If you would like to advocate for healthcare workplace mental health wellness, check out the links in our show notes and support their crucial work. This also might be helpful if you're working with a healthcare professional about the stigma in the workplace. Potentially you can bring it up with your clients or just discuss how this affects them. Next, in the headlines, New York City will hospitalize more people with mental illness involuntarily. New York City Mayor Eric Adams says the NYPD, FDNY, and other city agencies will start forcing houseless individuals who are determined to be suffering a mental health crisis off the streets and out of the subway system. They will be taken to a hospital for evaluation, even if they refuse to go on their own.
If severe mental illness is causing someone to be unsheltered and a danger to themselves, we have a moral obligation to help them get the treatment and care they need.
The directive has stoked outrage, controversy, and debate about homelessness and mental illness and how to tackle both issues. Frequently, houseless individuals with severe mental illness are brought to hospitals only to be discharged a few days later when their conditions improve slightly. Mr. Adams said the city would direct hospitals to keep those patients until they are stable and to discharge them only when there is a workable plan in place to connect them with ongoing care. Hospitals often cite a shortage of psychiatric beds as the reason for discharging patients, but the mayor said that the city would make sure there were enough beds for people who are removed. He noted that Governor Kathy Hochul had agreed to add 50 new psychiatric beds. "We are going to find a bed for everyone," Mr. Adams said. Asked about the legality of holding people involuntarily, Brendan McGuire, chief counsel to the mayor, said on Tuesday that people would be held under a state mental hygiene law that allows for involuntary commitment if they are a threat to themselves or others. Mr. McGuire said that workers would assess people on a case-by-case basis, including whether they were able to provide basic needs such as food, shelter, and health care for themselves. The state law on involuntary hospitalization empowers the police to have someone taken to the hospital only if the person appears to be mentally ill and is conducting himself or herself in a manner which is likely to result in serious harm to the person or others. Guidance issued by the state in February said that the standard includes people who, quote, display an inability to meet basic living needs, and that limiting it to only people who present as imminently dangerous leaves vulnerable people at risk. The police, along with emergency medical workers and other responders, are going to be trained on how to use those assessments. They'll be given a hotline to call, staffed by clinicians to advise them on these decisions. PBS NewsHour covered this story and interviewed Dr. Sam Tessimbris, clinical psychologist who also developed the Housing First program.
Apparently a danger to themselves or gravely disabled off the streets involuntarily, bring them to the hospital for treatment. And this was an idea of a compassionate approach, as Mayor Adams just said, a moral obligation to do something about homelessness. Yes, we do have a moral obligation to do something about homelessness, but that something has to be informed by evidence and experience. We already know that involuntary treatment in a psychiatric hospital is not a solution to homelessness. Housing is a solution to homelessness, and follow-up mental health support services are what helps people with mental illness do better.
Critics of the initiative discuss how the NYPD has long been accused of mistreatment and criminalization of citizens experiencing mental illness or in a crisis, according to past reports from the Urban Justice Center, New York University, and more. People experiencing homelessness and mental illness are more likely to be incarcerated, with one study from the Vera Institute of Justice saying, quote, "This crisis is perpetuated by a legal system that criminalizes survival behaviors associated with homelessness, fails to account for the ways in which people who are homeless face impossible odds within the legal process, and then releases them back into the community with even more obstacles than they faced before," end quote. Advocates say that involuntary hospitalization is a violation of civil rights and is a form of incarceration for innocent, unhoused, and mentally ill citizens of New York. Dr. Sam Tessimbris again.
Thing that the critics have really jumped on, that if you're asking police to take people against their will, that may be illegal, and they argue it is certainly unethical. Do you think it is humane and or effective to press people who might be resisting treatment into treatment?
I don't think treatment actually works in a coercive manner. It works much better when the person is offered options. When we started the Housing First program, it was exactly after 5 years of this coercive taking people to the hospital, they stay a month and then they're discharged back to the street with no housing. And these repeated failures led us to do something different, which is much more effective. We do need to intervene when someone is actually a danger to themselves. You know, if they're coughing up blood or they have wounds, there are emergency situations. But we already have mental health laws that address these quite adequately, and they're often enacted by a psychiatrist or a social worker or a nurse. Police officers are about enforcement and public safety. They're not clinicians, and it's really a questionable practice to put that kind of decision-making authority into the hands of the police.
Forcing people into treatment is a failed strategy for connecting people to long-term treatment and care, said the New York Civil Liberties Union Executive Director Donna Lieberman. Quote, the decades-old practice of sweeping deep-seated problems out of public view may play well for the politicians, but the problems will persist for vulnerable people in desperate need of government services and for New Yorkers. In a New York Times article, the issue of random acts of violence, mostly taking place in the subway systems, has become a concern for city officials and residents.
And a lot of them are talking to themselves, and it's not fair to them. They need help.
He might be standing in this corner right here, and you walk by, and then he'll jump out and scare you.
We really would love to see the city do something to improve the situation.
You all know it. You're watching people standing there on the street talking to themselves, don't have shoes on, shadow boxing, unkept.
Let's talk about where those perceptions come from first. Riders' perceptions that subways are unsafe are driven by two things. One, their own experience of dealing with people on the platform or the train who seem unstable enough that they might lash out. And two, media reports about crime. The statistics are not encouraging, though. Through October, felony assaults, murders, and rapes in the subway system, all crimes that are likely to be random, were up 20% compared with the same period last year. Property crimes, including robberies, which can be violent, were up even more. This jump in crime has occurred despite several efforts by Mayor Adams to flood the transit system with the police. The tactic of involuntary hospitalizations to curb crime is nothing new in the U.S. Other local governments are relying on similar measures to address mental health issues in their communities. Like California Governor Gavin Newsom recently signed a law that could force treatment on homeless people suffering from disorders like schizophrenia. Last time, I'm just going to share one more clip with that PBS interview to end this segment.
I mean, one of the problems, as I think you know, is that New York City has suffered several terrible violent attacks by people who are mentally ill and living on the streets. And again, we should caveat this by saying that mentally ill people are much more likely to be the victims of violence than the perpetrators of it. But many people argue that they feel terrorized and the city has to do something. The remedies that you're talking about have been very difficult to fund and to implement. So what would you like to see if you were counseling the mayor of New York City or the mayor of any big city? What would you be counseling them to be doing?
I would be counseling them to take an evidence-based approach. I think caution and public safety are a huge issue. They are random acts of violence, as you say, so that's not really our big problem or frequently occurring problem. The most frequently occurring problem is that we have people roaming the streets who are clearly disabled, clearly need assistance, and clearly need housing. So the focus has to be on addressing the homelessness first for all of our sakes, not just for the folks that are homeless, for all of our sakes. We would have a safer, healthier, better environment. We actually did this during the pandemic. At the height of the pandemic, before the vaccine, we would put people into the empty hotels because we knew that a safe space is exactly what people who are homeless needed to stay safe themselves, keep the rest of us safe, and people did much better.
Next, did you know that there is a rare mental health condition called the Stendhal syndrome? Say that 3 times really fast. Those with Stendhal syndrome experience physical and emotional anxiety as well as panic attacks, dissociative experiences, confusion, and hallucinations when exposed to art. These symptoms are usually triggered by art that is perceived as particularly beautiful, or when the individual is exposed to large quantities of art that are concentrated in a single place, such as a museum or gallery, according to Medscape. However, individuals may experience similar reactions to beauty in nature. This syndrome is named after a 19th century French author who experienced the symptoms during a trip to Florence in 1817. Stendhal syndrome may also be called hyperculturemia or the Florence syndrome. Not least, Resource of the Month. We recently asked the clinical team at Bridge Counseling and Wellness in Louisville, Kentucky, what were their most frequent resources that they share with clients, and podcasts were the winner. The podcasts that they recommended the most were Brené Brown, Unlocking Us, Herself, and Terrible Thanks for Asking. Give those a listen and see what you think and if they'd be a good fit for your clients. And that about wraps up our mental health news updates. Do you have any interesting news to share? We would love to hear it. You can send us a voice recording via SpeakPipe, or you can always reach out on www.academyimh.com.